Sodium oxybate, which is indicated by the FDA to treat narcolepsy, has a high sodium content. Patients with narcolepsy are known to have an increased risk for developing hypertension and cardiovascular diseases. Some pharmacotherapies used to treat narcolepsy may potentially contribute to these risks. Hello, I'm Dr. William White from the Cardiology Center at the University of Connecticut School of Medicine in Farmington. On behalf of my co-authors, I would like to discuss our article published in the Mayo Clinic Proceedings that reports the risk of patients with narcolepsy developing hypertension while they were taking sodium oxybate compared with the risk of those who did not initiate sodium oxybate. Sodium oxybate is one of several narcolepsy treatments considered standard of care by the American Academy of Sleep Medicine. At standard doses of sodium oxybate, 6 to 9 grams administered each night, patients will receive 1,100 to 1,640 milligrams of sodium. The FDA label for sodium oxybate includes a sodium content warning and recommends that prescribers monitor patients who are sensitive to high sodium intake. So what is the takeaway message of our article? Well, compared with the non-use of sodium oxybate, initiation of the medication was associated with an increase in new onset hypertension or the initiation of antihypertensive therapy within 6 months in narcolepsy patients without a history of hypertension. Our observational study evaluated narcolepsy patients retrospectively using insurance claims data from January 2014 to February 2020. After February 2020, the impact of the COVID-19 pandemic markedly affected medical care and clinical visits. Hence, we truncated our analysis at that time. Patients initiating sodium oxybate, known as the sodium oxybate cohort, and patients who did not receive sodium oxybate, known as the control cohort, were balanced for baseline characteristics using a 1-to-2 propensity score matching ratio. 2 endpoints were evaluated. First, a composite of a diagnosis of new onset hypertension or the initiation of a prescription for an antihypertensive medication. The second endpoint was simply a diagnosis of new onset hypertension. The composite endpoint provides a sensitive, clinically relevant method for identifying hypertension because using diagnostic codes to identify hypertension may lead to underreporting in the medical record, particularly among specialists who do not focus on hypertension management and use billing codes within their specialty. The incident rates for both endpoints were higher in the sodium oxybate cohort within 6 months of initiating sodium oxybate compared to the control cohort. As shown in this figure, the composite endpoint occurred in 6.6 per 100 patients in the sodium oxybate cohort versus 4.2 per 100 patients in the control cohort. The odds for the composite of developing hypertension or being initiated on an antihypertensive medication were statistically significant. However, the odds of developing hypertension alone were not, potentially because of the small number of events. How does this finding relate to our clinical practice? Well, first, in lifestyle management, for those at risk of developing hypertension or those who have hypertension, dietary salt reductions are usually recommended, but less attention is placed on pharmaceutical sodium content. Given the underlying risk of cardiovascular conditions observed in the narcolepsy population, the high sodium content in sodium oxybate is of concern. The American College of Cardiology and the American Heart Association suggest that clinicians recommend lifestyle modifications, including reduction of sodium intake, before prescribing antihypertensive medication. In patients with narcolepsy, lower sodium drug formulations would be an appropriate treatment strategy to help mitigate this risk. So what does this finding mean for our patients? Well, previous research has shown that small to moderate increases in total sodium intake are clinically important to all patients, regardless of age, hypertension history, and race. As shown in a landmark study by Bibbins Domingo and colleagues, published in 2010 in the New England Journal of Medicine, a daily reduction of 3 grams of salt, or about 1,163 milligrams of sodium, would substantially reduce the development of hypertension, cardiovascular disease burden in the general population. There are even greater impacts of sodium reduction in older people, African American people, and people with hypertension. These findings suggest that patients with narcolepsy may benefit by taking lower sodium drug therapies to reduce their risk of developing hypertension and cardiovascular disease. So what's next in this line of research? Well, keep in mind that our study is an observational analysis that generates important hypotheses, but is not definitive research. To better define the impact of high versus low sodium oxybate on blood pressure and the development of hypertension in patients with narcolepsy, future research should evaluate the impact of switching from high sodium oxybate to lower sodium treatments on both office and out-of-office blood pressure. In conclusion, we hope that you find this information from this video and our article of scientific and clinical value. Thank you so much for listening.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.